Hi, I'm Gretchen Burns Bergman, co-founder and executive director of A New Path, Parents for Addiction Treatment and Healing. We work to reduce the stigma associated with substance use disorders, and we advocate for therapeutic rather than punitive drug policies. We're proud to present the Unsung Harm Reduction Hero, Clinical Case Management. I will act as moderator and introduce our panelists. Caroline Stewart, L.C.S.W, President of the Board of A New Path and Clinical Director of Caroline Stewart and Associates. Kelley Gebbie, Case Manager, Homeless Women's Services and Vice President of the Board of Directors of A New Path. And Lucky Michael, Addressing Needs of Homeless with Co-occurring Disorders, a board member of A New Path. And we'll start with Caroline Stewart.
Thank you so much. So it's such an honor to be here with you all. I have attended many meetings of the minds and had a very edifying experience. I hope you enjoy our panel today. I have come to you, I came up with this idea for the need for us to have a more open community dialogue about the huge need for more case management and particularly clinical case management, but all forms of case management for our vulnerable citizens. The fact of the matter is I came to this idea because I'm a psychotherapist. I was actually originally trained in psychoanalytic psychotherapy, which is a very kind of a distant, aloof model where the therapist is not that personally engaged with the client. And what I have found out over the years is that I love my profession, but even I, who am a pretty direct and engaged psychotherapist, that we live in a little bit either in a bubble or in an ivory tower, because our patients need way, way more than simply sitting with us for 50 minutes a week and discussing their issues. They need active harm reduction, and they need case management, because that is not something that we're overdoing for our patients. I think in therapy, we've been taught, maybe wrongly so, that we should support the autonomy of the patient. And historically, I was taught not even to give advice in psychotherapy. So the thing is that I'm here today wearing many hats. And because I'm a psychotherapist who wears many hats, including one hat that I'm the mother of a son with a very severe, long history of opioid dependency, I have learned that if my son simply meets weekly with a therapist, that is in no way going to meet his complex needs. So what are some of my hats? As a clinical therapist, a social worker, for on and off for 20 years, I had a intake team that I oversaw at Gifford Clinic. And I will tell you this, a majority of our patients who were presenting with psychiatric problems, upwards of 80% suffered from substance use disorders as well. So, and so this business of thinking that people need to be self-reliant, they don't need shepherding, they don't need help from other people, except just simply to come into therapy and tell their story. I learned from 20 years of really hands-on experience with lovely people who were suffering. Many of them were homeless, many of them had been estranged from their families. It wasn't going to ever be enough simply to sit with me in a psychotherapy session. So that is the root of today's panel. So my son has been homeless, and I think that is a story about case management as well, because I attempted to reach out and get aggressive psychiatric care for him. He was having a meltdown in our home, and I called the psychiatric emergency response team, and 8 police cars show up and throw our son to the ground very hard. I'm very pleased that he did not hit his head. He was then forced, we as a family, my husband and I, because we're seniors, forced into filing a restraining order against our psychiatrically ill son because he had yelled at us. He hadn't hurt us. He had simply, he did have some psychotic language, but they forced us. They said they would file an elder abuse charge against him and he would go to prison for 6 years. So the police forced us to file this restraining order, which then found our son homeless for 18 months. Here's an example where there was no case management. Our son was on methadone and his homeless encampment was literally several miles from the methadone clinic. I don't know if you all know this. We have to go daily to the methadone clinic. He had no bus pass. We were not supposed to help him, meaning if we had been the case managers in the past, we were cut off from assisting him. So what happened is that he was put in this position of having to walk miles and miles every day from his homeless encampment to the methadone clinic. And I'm telling you, the methadone clinic provided no case management. There was no help. I think every 3 weeks there was like a 20-minute group therapy. There was very impaired case management. So here, his only contact with providers, whether clinical or otherwise, was at the methadone clinic, and then he lived in his homeless encampment. It was heartbreakingly deficient. So the other thing I would say is that after our son was homeless, he wound up going to jail for complex reasons. And here's another example of biopsychosocial kind of estrangement from my son. When my son came out of jail, the very morning he moved from George Bailey, he was placed in a very prominent residential treatment program for a substance use disorder that very morning. He did very well there. He was in this program for 3 months. When he came out, he was re-jailed. You want to know why? Because his treatment program never shepherded him, and he didn't know. Our son's severely learning disabled. They never worked with him to contact the probation department. So then he was perceived as breaking the rules of probation. That's basically the big no-no. Wouldn't you think that there would be someone at the residential treatment program that would say, hey guy, you got to call your PO? No one ever did. And so he returned to jail. I have to say, since he's been discharged then from jail, it's been a wonderful experience. He entered a sober living that had very aggressive oversight. He was in one sober living for 4 months that provided no drug testing, no case management, no dialogue, no support, no social worker, and no one encouraged him to care for him. The other thing I would say is, historically, my son's providers, they don't know anything about his psychological state. Our son still needs he should have a neuropsych assessment, and that would tell all of us what is he capable of doing? Is he capable of graduating from high school? Is he capable of doing computers? But the presumption is that we're all the same, that everybody is cut from the same cloth. The residential treatment programs believe we're all cut from the same cloth. The therapists too often think we're all cut from the same cloth. The fact is no one has ever assisted our son except his father and me to get Social Security disability. I'm not saying he'd get it, because I know with a substance use disorder, it's close to impossible to get that. But we have been trained as clinicians that modern psychiatry understands that substance use disorders are not a character defect or a moral failing, but a brain disorder. Why would we ask an Alzheimer's patient to, basically to go to college if we knew that they could not even do that mental processing? Our son has been told he has to get a certain educational level, or he's then breaking the mandate of his probation, and they don't even know what his learning disability is. So the point of my thing is that we have to understand the whole person, the context of that person's lives. For example, our son's person in seeing is that he has very actively engaged parents. My husband had to become the case manager, and he literally shepherded our son regularly and understood both his strengths and his weaknesses. And that there ideally would be a setting in which a person could enter that setting for care that would include the psychiatric, the substance use, and the case management needs, such as the neuropsych assessment to find out what kind of work can this person do? What is a likely outcome? Does this person need Social Security disability? These questions are never asked. So basically, a clinically informed case manager understands that attending to the complex variables that weave together to create one person's idiosyncratic narrative can deeply influence the client's capacity for decision-making, our opportunities, the client's opportunities and options, insights, and sense of mission. Our son is now almost 2 years sober, thanks to clinical case managers such as Kelley and Lucky, who will be speaking. It's because of that aggressive shepherding that happens. Years ago, our family had a little corgi dog, and corgis are cattle dogs. And one thing we noticed about our little dog, whose name, by the way, was Morgana. She was gifted to us because she was named after our son when he was a baby. Anyway, so Morgana, one thing we would notice when she wanted us to move into a particular room in the house, she would nudge us. She wouldn't bite us. She never broke the skin. She would lick us or nudge us and say, come on, let's go. So that's what I called shepherding. What I tell my patients is, I know you feel despair, you've lost your sense of mission, you don't know what the future lies for you, you don't know what your abilities are. And I say to them, and I'm not saying I wear a cape, I do not wear a cape, but I say to them, hang on to my cape. You fly with me, I'll take you wherever you need to go. I'll set you up. I'll help you learn how to use the computer. I'll help you enroll for your high school diploma. These are things I can do as a case manager. As a psychotherapist, I don't want to sit in a tower and pontificate about whether you had a loving mother or not. I want you to have a functional, happy life. And so this is my issues. Those who suffer from substance use disorders sometimes have poor insight and self-awareness. Many people with psychiatric illness don't know how ill they are. Our son is just now, last night we had a wedding at our house, and our son's younger brother got married, and we were so impressed with our older son comfortably talking about the insights he's had about his 20 years of substance use and how it tragically separated him from his brother, who he just adores. So many individuals with addictive illness are fed up with parental intervention. They don't want their mother shepherding them. They would love a neutral party without the old business. So turning treatment planning over to case managers can help all of us get involved to avoid the toxic component of extortion. So like our son used to sometimes, if we say, we want you to go to high school, he might say, well, I need a new scooter to get there. And that wasn't the best relationship. So I think that's something that happens when we have a neutral case manager, a caring case manager, but not someone that can get caught up into family business. Okay, so I think I'm very delighted to introduce you now to my dear, my neighbor, Kelley Gebbie, and Kelley, who works at the Rachel's Women's Center, and she's a case manager for homeless women. And then after that, Lucky Michael will be speaking. Thank you so much.
Hello, everybody. I'm going to talk about the special needs of women seeking harm reduction. My name is Kelley Gebbie, and I have worked in homeless services for the last 14 years in a prominent nonprofit in San Diego that provides homeless services in a trauma-informed environment as a housing resource specialist. Women come with their own needs and issues, and today I want to speak about those needs and that women face in harm reduction. Historically, homeless agencies were about abstinence, the voice of 12-step programs. Harm reduction is a relatively new concept to our programs. Some employers fought the transition to harm reduction. When the staff are not on board, we struggle. Change is hard. Imagine a mom suffering some substance abuse disorder coming forward, admitting to use. In the past, she ran the risk of losing her children or at the least having CPS involved. Many of these women have trust issues with the state agencies that have failed them in the past. Now we tell them we're going to meet them through a trauma-informed lens with harm reduction. This comes with a lot of stigma attached. As a case manager, I must build that trust with the participants so that they may hear the message. These women fear that they will be arrested if they admit to using or be denied access to services and resources to offer basic safety. We tell them we will find them a program that will take them with their children. There are not enough beds in the county for these families, and when they do seek help, eventually they give up trying. It may come down to them having to choose between their treatment and their children. As can be seen, moms have overwhelmingly been targeted about this use. Next slide, please. Pregnant women face a difficult choice about admitting to use. Women are faced with stigma and shame if it is known that they have substance abuse issues. Then we offer harm reduction. When a woman finds herself pregnant, it does not mean she can immediately stop using. She may want to stop and hope she can stop, but that just may not be the case. And then there is our current opioid crisis. It may not be possible for her to stop. So we offer harm reduction. As a pregnant woman walks into a MAC clinic, she feels looked down on all the others at the clinic. These are the same people that are going there seeking the same services as she is, but of course she's pregnant. She knows she would like to stop, and now that she's bringing a new life into the world, many will not seek prenatal care for fear of retaliation, stigma for fear of losing the baby through the system, and the stigma that they will receive sometimes from their own doctor. They are afraid to go to the needle exchange where they can receive clean, free needles. So much shame is forced on the pregnancy and the substance use. These women will hide. Women often support their substance use with prostitution. Sometimes it is by choice, and other times it is forced on them. Many women with substance use will stay with an abuser due to the loss of self-esteem and the financial burden that they will suffer if they leave. A woman may also be the caregiver for their abuser. The abuse may have led to their substance abuse in the first place. With harm reduction, you can pass the slide on. With harm reduction, we must first earn the trust of those we are case managing. We will need to understand the trauma they have suffered that may have led them to their substance use. Overall, we must meet harm reduction with the overall care of women where she is coming from and when she will need to be successful. In wrapping up, women from all backgrounds who are seeking help can best be assessed when we look through the lens of harm reduction, which meshes easily with our trauma-informed approach to services. Women often come with a loss of sense of self. Single women, mothers, pregnant women, we need to meet each where they are at. Imagine a woman coming forward, asking for help, knowing in the back of her mind she may lose her children. This view on society that society puts on the using mom. Harm reduction. It does not matter how we get there, but that we'd get there. At times it appears harm reductionists and 12-step programs do not see eye to eye. It is about getting well, no matter how we get there. There is never a threat when programs collide, but a learning and growing experience. Harm reduction is the future. It is about saving lives. In this current health crisis, we must all work together. There is always room for an open mind. Thank you. And now I'll introduce Lucky Michael.
Hi, everyone. Thank you, Kelley. Hi, everyone. I'm Lucky Michael, and I've been in service to folks experiencing homelessness and living with substance use disorders and serious mental illness. As Caroline and Kelley have both mentioned, some of the stigmas that they endure in experiencing the indignity of poverty and these clinical disorders, right? What we know that by evidence, of course, is what works in solving some of these problems are, in regard to homelessness, is housing, right? When folks are out on the streets and don't have access to treatment or care, in the long run, we know that that results in the likelihood of death. So shepherding folks and providing treatment and services in a trauma-informed manner, and taking into consideration that the people that we are in service to have experienced lots of trauma in their life and are re-victimized by simply being homeless and on the streets. So a lot of, especially those special, oh, I'm so sorry, Caroline. Can we start again?
You're fine. Keep going, Lucky. You're fine.
Especially those who are in our special populations, those who are on the LGBT spectrums, especially trans women involved in sex trade, our immigrant community who oftentimes do not go to treatment or care because of stigma issues, and providing culturally sensitive materials that caters to that community. So again, some of the resources that do work is, of course, treatment and treatment on demand, the treatment that's also coupled with the understanding that it's going to take some time for folks to get better, and we need to change our mindset and do whatever we can to reduce as much harm to the people that we're providing services for. So what does that look like in our systems of care, in our shelter opportunities, and in our case management roles, and in our substance abuse treatment programs, substance use disorder treatment programs? It looks like unconditional positive regard. It looks like, to Caroline's point, shepherding people through their trauma and recognizing that it will take time for people to heal, but the more we create a loving, supportive environment, the easier that the journey of healing gets for them. So those are some of the things that we can do in our systems of care. I know that Caroline and Kelley have shared some personal stories, of course, and in ways that substance use disorders have affected them and their families. I myself had a loving family member that also is living with substance use disorder, and having worked in this community for a long time now, and understanding all the resources and how to navigate people in connecting them in those resources, my family and I also struggled with that. And it was extremely painful to see someone that you love so much, and with the working knowledge of how to get them the help that they need, struggle with, entering detox programs, staying there, trying to connect them with longer term treatment, and witnessing them falling back out. And with that knowledge, I had to also care for my family members who were also struggling with how to cope with our loved one experiencing these destructive patterns and this illness. And again, despite all the resource knowledge that I might have, so we implemented that, right, in our program, in our family, reducing as much harm to him as possible, allowing him to come into our family home when he was safe and ready, or, to get him out of the elements, right? So that's within his family support network. Some of the folks that we're talking about who are out there don't have that. They don't have family here. They don't have loved ones. They don't have a home to go to. They may not have family members. So the more we can do in clinical settings and in the service provision world to create that sense of love and belonging and destigmatization and welcoming folks in, and recognizing that it's going to take 5 times, 10 times, 20 times, or however long it needs to take for folks to have it stick and get better and heal from these things, the better, right? And granted, it's difficult work that we do. It's emotionally exhausting, but the more we create cultures around being, again, trauma-informed and reducing as much harm to the folks that we're serving as possible, the better we can heal people in our community.
Thank you.
I know that I probably am not forwarding the slides according to your talk, but lucky, you know, 1 in 3 families deals directly with a loved one who struggles with a substance use disorder. And because of stigma and shame, it is still, I mean, it's painful anyway, but that really exacerbates the problem. And I appreciate all of you sharing your personal stories because that's the only way we're going to break through the shame. And I know that in your talk, you mentioned treatment on demand. Yes, that's the kind of a world that we want to see. I don't know if you wanted to address, I think you did address some of these things, but if you want to go over your last slide a little bit more.
Absolutely. So yeah, back to treatment on demand. It's critical that we have treatment readily available, because there's a small window of time. By the time the folks that we're talking about are ready for it and are willing to enter treatment, they have to go through the rigmarole of calling and waiting for bed opportunities, right? So, and even mathematically, you can probably safely calculate that the amount of funds that we're spending in incarcerating people and keeping them locked up for these issues, you know, we could probably redirect those funds into beds and create opportunities to have treatment on demand, coupled with medication assisted treatment, right? So even in my brother's or my family member's case, he was in a lot of physical pain. He needed the medication to help him stay in detox and hopefully enter longer term treatment. That was really difficult for him because he wasn't given the opportunity to have those resources while he was there. So treatment on demand, certainly, but also medication assisted treatment, because that would be the whole goal, is to make sure that they enter treatment, but stay the whole course and finish detox and get into longer term treatment programs. And I know Kelley touched on this earlier, but 12-step programs do work, NA and AA do work for some, but it's not the only path for everyone. So we need to be a little bit more open-minded in the therapeutic interventions that we are providing to people, and taking into consideration that there are many paths to recovery, and giving people the opportunities to explore the different paths that might work best for them.
I'd like to comment on treatment of demand also. I was thinking of someone that we here at A New Path have always loved and valued, and that is Gabor Mate. And basically, Dr. Mate, many years ago in Vancouver, developed a hotel, and it is a one-stop shopping hotel. What I always loved about it, when you enter on the first floor, if you struggle with a substance use disorder, you can actually go and get clean needles, you can get lunch, you can have a shower, you can speak with a social worker, and you can leave at any time. There's no moral judgment. There is no punitive judgment whatsoever. The police have nothing to do with this. If you opt to, you may go upstairs and tell the people that you would like to explore treatment. You can then decide to enter treatment. And while you're in treatment, you're welcome there. It includes MAT, medication-assisted treatment, such as methadone and Suboxone. If you do well in treatment and you're happy and you like the hotel, you can go upstairs and get your diploma from high school or get job training. And then when you've been there a while, you're welcome to just be a resident in the hotel and live in one of the hotel rooms on the top floors and go to work every day and have a wonderful life. Anytime if there is a reoccurrence of the substance use, they don't kick you out. You simply are welcome to come back on the first floor, use if you like. There's people there that care about you, going to give you food. They're going to make sure you have clean needles. I guess what I think of, I used to be a neonatal intensive care unit social worker. And what we always said about the babies, wherever you are, you're welcome here. You're always welcome. No one's kicked to the curb. You can have acute care or very low level of care, but you're welcome. And I've always thought that the treatment on demand should include housing, case management, educational assessment and support. Now it would be computer. But basically, we need to listen to these wise people like Dr. Gabor Mate. Why does not every city have 2 Vancouver hotels for our family members, where you're always welcome? And that's what I aspire to. And I think that's an excellent example of treatment on demand.
I'd like to go to Kelley to ask you a question. What are some of the unique case management needs of women?
Well, I will tell you right now, in our current health crisis of COVID, I work with homeless women and they don't have technology. They don't, and so many of the case management, the visits are all on the phone. And how are they to reach out? They are stranded without any care because they don't have access to technology, have a space that they can, they have an Obama phone, but it doesn't have data on it, or, things of this nature. So it makes it really hard. And in our facility, we don't have a private place for them to sit and maybe have a face-to-face with over the phone with some of their private care. It really is an issue. And so they're falling behind, they're falling out. People are falling out into gambling, into their drug and alcohol, even more fierce before this episode happened, because everything is falling apart. Their mental health is going pieces, or things that they didn't even struggle with in the first place are starting to come up. And it's all because they don't have access to the services.
I would add, it's also, it's especially women, but I will say that our son, who's 39, was basically disengaged from any training or education for 25 years. So he only now has had a computer for 1 year. He still struggles. He'd never had computer training. And it is a terrible source of alienation for the homeless, particularly. I think all of us that are here today, I have been using technology daily for 20 years, and I still find it daunting. I find that some days I want to throw the computer through the window. So distressing, so hard to use. Imagine our family members who suffer from co-occurring disorders, and many of them do have learning disabilities. They feel so grossly estranged from our society, because we are now close to 100% technical. And so we very much need to involve more technical training of these family members.
Thank you. I have a question for Lucky. How can clinical case management help the homeless when there's no housing? You can respond, or any of the three of you can respond to that, because we know this is you're talking about technical difficulties. If you can't even access housing, much less technical devices during this dual crisis of COVID-19 and opioid overdose, anybody that wants to address that.
Well,
in a little bit. I mean,
oh yeah, no, Lucky, you go ahead.
Certainly, I mean, the digital divide is something that's, as we know, is affecting a lot of people, not just, throughout the country, right? We know that to be the case, but even more so, of course, when we're talking about people experiencing homelessness, right? And kind of that tier, like there's people who are experiencing poverty, and then these folks have absolutely nothing. So to answer your question, how can clinical case management be, effective in providing services to people who don't have housing? Great question. They are there, as Caroline says, to shepherd people into that. Ultimately, nothing is going to improve in anyone's quality of life unless they have a place to live and not be out on the streets. Quite frankly, we are Californians, and 5th largest economy in the entire world. There is absolutely no reason why we should have anyone living on our streets. There's no reason for that. We love to tout that about our community, and there's this notion of scarcity, as if, well, there's no place to build, or there's just not enough housing. That's true, there's not enough housing, but we could bridge that gap by, of course, developing more housing opportunities, but also recognizing that some people just need ongoing rental assistance and ongoing rental supports until they're able to self-sustain. And predictably, we're going to see a lot of folks who are going to suffer with that, especially now that there's no job opportunities. Of course, COVID adds an extra layer behind that. So to answer your question, I think clinical case management is important and it can be effective, but in shepherding people to services and resources. But as you know, it's only going to get as good as folks have access to basic things that every human being needs, right? Food, shelter, clothing, and a place to live. That touches everything. Even if you were medication compliant and seeing a therapist and, you know, engaged in treatment, how will you continue that if you don't have a place to live and if you're not somewhere safe? Right. That's just the reality of what folks are dealing with who are living out on the streets. And we, certainly I'm not representing any organization while I say this, just me, myself, and my personal views. Scarcity is a myth. We have the money, we have the resources to, you know, improve the quality of life of people who are experiencing extreme poverty in our community. It's shameful. It's shameful for a lot of our service providers to have to vie for the same pool of resources and constantly knock and beg for, you know, some of the most basic tools that they even need to be able to get people, again, into like housing opportunities or in a better situation, again, to improve their quality of life. But we have the money there. It's just a matter of willingness to redirect them in areas that we know already that are effective, right? Intuitively, we know as human beings, no one belongs on the streets, right? No one's gonna do well. No one's gonna, you know, magically just get better sleeping in an alleyway. That just doesn't work. That's just, we're all bright people. And I'm sure folks who are attending this conference are extremely highly educated, great people who've been in the service of people experiencing mental illness and substance use disorders and poverty and trauma. So we know at the end of the day, people need a place to call home. People need a place to live before we can even fully explore their potential to heal and get better.
So I would say a huge barrier is kind of a common term, but NIMBYism is a big problem because here in Mission Hills, where I live, we have an old library that was built in the 1960s. It was going to be reconverted into and made into a 3-story home, a sustained living, not a drop-in center, not a shelter, but a sustained living for 28 homeless families. Well, guess what, folks? Our lovely Mission Hills neighbors have now designated the Mission Hills Library as a historic site. I'll say that again. It was built in the 60s. So it is now a historic site, and it's not going to be available for housing 28 homeless families with case management. So the NIMBYism is gross. I have one other comment. I have a friend who's an architect. He told me 75% of the office space is going to be available because of COVID. People are going home to work. Why could we not take the 75% of open office space and reconvert it for the homeless? If we don't do that, it's because of contempt, arrogance, ego, and values that I hope none of my friends share. It's not appropriate.
And I would like to also add that once we do establish a home for somebody, then a new life begins, and we can't stop there. We have to continue with the clinical case management, even maybe at a more intense level, because now they have a home, but we have to teach them how to live in there, because these are skills that they have lost along the way just being on survival mode. So so many programs in the past, you give them the door key and you walk away. No. We have to continue the care, the guidance, the shepherding, everything. It's just at a new level, and it's even more acute that it happens right now.
Thank you. We have about 3 minutes left, and I could toss it back to Caroline with, I think you've already addressed some of this, but you might want to say a bit more. What are some of the most egregious barriers to those suffering from co-occurring disorders that can be overcome with good clinical case management?
I guess the whole point of this is why did we insert harm reduction in the title? Because I think, 100 years of AA and abstinence-based philosophy no longer is the bottom line for the right direction to go in for our clients, and that an abstinence-based belief system will harm our clients and it will, and our children and our family members. We need to have a harm reductionist mental attitude, but the biggest barrier would be abstinence-based thinking. It's not that people that are abstinent can't remain abstinent. I celebrate that, no problem. But what those folks dictate to everyone else that they're morally inept and they're bad people because they're not abstinent, that is not the direction we need to be going. And so I would say the biggest barrier is if there's categorical, rigid, abstinence-based philosophy pushing people where they don't feel welcome in the meeting rooms, that the sober livings are not welcoming them because they're on MAT. Those are some of the really essential problems.
A good example of how stigma runs deep, and it continues in all forms and even in the meeting rooms and the recovery support systems. So we really need to address that. Well, thank you. I have about 1 minute left. So if you want a last comment, Kelley, anything you want to leave?
I'd just like to add on, in my own personal family issues, we've had a family member get some time and then lose it. And so it's always a journey. It's not, a race to be across the finish line. We must always continue to seek care and encourage.
Thank you. And Lucky, any last comment?
I'd say unconditional positive regard. And we're talking about people with living with SUD issues. These are our neighbors, our family members, people that we know and love. So just unconditional positive regard, it works. Now we've learned to use different terminology, but essentially having love for people and having love for our brothers and sisters.
Hallelujah. Yes.
And thank you so much, Caroline, Lucky, and Kelley. We've reached the end, and thank you all for joining us for this session. Thank you.
Thank you. Thank you.
Thank you.